Good evening. My name's Sara Suliman. I'm a consultant endocrinologist at Imperial College London Diabetes Centre in Abu Dhabi, and today I'll be sharing my presentation on COVID and diabetes. I have no disclosures. So COVID-19 is, I'm sure as everyone knows, is a SARS-CoV-2 disease, viral infection caused by a single-stranded RNA virus of the coronavirus family. It's related to the SARS virus, which was detected in Hong Kong in 2012, and the MERS virus, which was detected in Saudi Arabia in 2003. It's originated from bats, moved on to pangolins and then humans. It's transmitted by personal contact. The word corona in coronavirus refers to the spike protein, which we can see here on the right. The red bits that are coming out of the virus. More recently, there's been emergence of multiple variants with apparent increased transmissibility, such as the Delta variant. And these have evaded vaccine-induced immunity and posed an ongoing concern. Thankfully, the most recent variant, Omicron, has been milder. However, one needs to be vigilant. We also know that there's a prolonged respiratory, cardiac, or neurological syndrome known as long COVID. So we spoke about the spike proteins on the outside of the virus. These attach to the ACE receptors on cells, which are expressed in the lung, upper respiratory tract, kidneys, possibly islets, and this cleaves the ACE2 and results in viral replication. So at the end of the first year, there was about 1.5 million deaths, and there were 65 million people affected. 11 months later, we had almost 4 times the infections and 3 times the death. And if we look at regions, Americans have been leading the way from the beginning of last year, with about 50 million people affected in March, and 8 months later, this had already doubled. We're already seeing in all the regions by the end of 2021 that there were 3 peaks, and this actually continued. More recently, we've had our 5th peak in the UAE, and the global situation is that at the moment, almost 500 million people have had COVID-19. The clinical spectrum of the disease ranges from a mild asymptomatic disease, where a person may transmit the virus but actually shows no symptoms, over to a mild disease, almost a flu-like illness, with fever, a cough, breathlessness, and classically loss of taste or smell. And about 20% of people have a severe disease, and this refers to the very original cohort. And certainly this has been shifted very strongly leftwards with vaccination. But 20% of the initial cohort required hospitalization, 75% of whom required oxygen, just less than 20% of them required ITU admission. Pulmonary failure, heart failure, myocardial infarcts, renal failure were common. There was also a high risk of thrombotic complications. Thankfully, all of that has reduced. What is not on there and is fairly important is a cytokine storm, or a pro-inflammatory situation, which also resulted in morbidity and mortality. So I'll just speak about a few bits relating to diabetes and COVID, looking at the proposed underlying biological mechanisms, looking at the increased risk of testing positive, shedding the virus for longer, hospitalization, ITU admission, and eventually mortality. There is reasonable evidence that severe COVID-19 can induce diabetes, and finally looking at how to manage patients with diabetes whilst they're infected with COVID-19. So this is a slide I'm very grateful to Donna Ryan for sharing. I have adapted, looking at COVID-19 severity and predisposing conditions such as obesity and diabetes, which have a pro-inflammatory state, immune dysfunction, pro-angiogenesis, endothelial inflammation, all of which make a human being more prone to more severe infection in general, but certainly so with COVID-19. Not only that, diabetes is associated with other comorbid conditions such as hypertension and cardiovascular disease, as well as renal dysfunction, all of which are independent risk factors for severe COVID and increased mortality. Moreover, patients who have COVID-19 then lack access to healthy food, they're stressed, they're isolated with minimal exercise and limited income, which makes diabetes worse and diabetes care worse, and it becomes a bit of a vicious cycle. So we spoke about the risk of testing positive, and the reason for that is the ACE2 receptor, which binds the virus, can be glycosylated in people with diabetes, and that facilitates the binding and viral entry. Also, glycosylation of ACE2 leads to reduced innate immunity, and therefore people are more susceptible to getting COVID-19. The risk of hospitalization in patients with diabetes is also higher, partly due to downregulation of ACE2 and accumulation of angiotensin II and poorer outcomes, but partly also these people already have a chronic inflammatory disease. And we spoke about the cytokine storm and having more severe disease, and therefore that contributes to it. Finally, patients with COVID-19, the virus can actually damage the beta cell itself, resulting in poorer glycemic control, which again can affect the immune system, but also hyperglycemia itself can induce the admission. This isn't just in adults, but even in children and adolescents who are admitted with COVID-19. We see that the risk of being admitted in 319 patients was very significantly linked with a P of less than 0.01 for both diabetes and obesity. And neither a previous history of asthma or social economic status, what we would consider classical determinants of admission with a respiratory infection, were not significantly associated in children and adolescents being admitted for COVID-19. People with COVID-19 also shed the virus for longer. So the red line is the time to negativity in individuals without diabetes, and the blue line is for people with diabetes. And as you can see, there's a rightward shift for maybe 3 or 4 days extra. Diabetes control during the admission is a predictor of poor prognosis, morbidity, and mortality, and that ranges from on top the admission diabetes to variation or glucose variability, minimum glucose, maximum glucose, but particularly so for the median glucose. Interestingly, hypoglycemia does not seem to confer an increased risk of morbidity or mortality. The risk of mortality, looking at a large study, was increased by about 50% in women diagnosed with diabetes, and about 80% in men. More interestingly, if you look at the red circles, people who were not diagnosed with diabetes or were diagnosed with diabetes on admission rather than having diabetes as a diagnosis beforehand had an even higher risk, particularly in men with an odds ratio of 3.5. If you look at the bottom section, it also becomes quite apparent that change in HbA1c confers an increased risk of about 4% per 1% HbA1c for women, and a 10% increased risk per 1% HbA1c. And when you get to an HbA1c of over 7.5%, we're looking at an odds ratio of over 2 for both men and women. This is a beautiful study which was done in the UK by Jonathan Valapji and a large collection of prominent physicians in the UK. It looked at all patients who had COVID-19 between March and May 2020, of whom 23,600 actually died of COVID-19. A third of the people who died of COVID-19 had diabetes. The majority had type 2 diabetes, about 5%, about 0.5% had type 1, and about 0.1% had other. And if you look at the 72-day adjusted mortality in people without diabetes, this was about 27 per 100,000. People with type 1 was about almost 140, and in people with type 2, almost double that. However, when this was adjusted for age, sex, socioeconomic status, ethnicity, the odds ratio for type 2 became 2, and for type 1, 3.5, although we'll discuss that a little later. Other factors that were significantly associated with mortality, including age. So for an age of over 80, it was an odds ratio of 9.2. Social deprivation, almost double. Diabetes, we've discussed already. And ethnicity, so blacks had a higher risk of mortality, and the whites had the least risk of mortality, as you can see. The other risk factors in type 2 diabetes, which were associated with worse prognosis, included increasing or worsening glycemic control, renal dysfunction, both limits of BMI, so obesity with a BMI of over 35 or a BMI of less than 20, probably suggesting cachexia or some other underlying disease, and cerebrovascular disease or heart failure. Similarly for type 1, the picture was very similar, except that HbA1c more than 10 became quite significant. Looking at another large Chinese study, this compared people with well-controlled versus poorly controlled diabetes, where well-controlled diabetes was a glucose of between 4 and 10, and this showed significant survival benefit with an increased death rate of 11% in those in the poorly controlled group compared to the well-controlled group. So in summary, type 2 diabetes was found to be an important risk factor for COVID progression and adverse endpoints. In those with good control, this was associated with a significant reduction in adverse outcome and mortality. Looking at type 1, the high-risk features included an age of over 50 years, prolonged diabetes, significantly poor control, and other comorbidities. And we've seen this slide already. So one of the questions that's been raised more recently is, can COVID-19 cause diabetes? And is this type of diabetes type 1 diabetes? Studies have shown that up to 50% of people who have severe COVID necessitating ITU admission can develop diabetes. In about less than half, it's transient, and these people can then develop normoglycemia. However, about 60% of people get persistent diabetes. So exposure to the virus can, particularly in those who get severe disease, can result in a cytokine storm, inflammation, insulin resistance, immune dysregulation. But actually, there is also an effect on the beta cells themselves, where the high ACE2 expression can cause damage and local inflammatory cytokine release, beta cell apoptosis, and decreased insulin secretion. It's probably not classical type 1 because those who were diagnosed do not have antibodies. There are other factors that are beyond just biology, such as psychological stress, lack of exercise, poor diet. So this was looked at. prospectively, people who develop diabetes more than 30 days after their COVID-19. And basically, what appears to be happening is that these people are more likely to receive a new diagnosis of diabetes. They have severe disease. However, it probably in about 40% can be reversed. And this is another study showing the same from a large US center. And what it shows is that people who are diagnosed with diabetes during COVID-19 have a lower glucose but more severe COVID. As we said, about half of them regress, and this appears to be a stress hyperglycemia rather than just beta cell destruction, although some of them do persist, or the majority of them do persist with diabetes or prediabetes. So how do we manage patients with diabetes during COVID-19? The key is actually prevention and education. So all the classic masking, hand washing, social distancing. Vaccination is as effective in this obese individuals or individuals with diabetes as those who have neither. We encourage our patients to take regular medication because well-controlled diabetes means they're less likely to get severe disease. There are more specific treatments with medication that we will discuss. Anti-inflammatory dexamethasone has come out as a strong winner in severe COVID, and some ITU basic care, including anticoagulation, ventilation, proning, dialysis as necessary. What about anti-diabetic medications that we can use in COVID-19? Metformin reduces insulin resistance, it reduces inflammation, it's an immune modulator. However, it can increase the risk of lactic acidosis and DKA. So the general rule is to continue in well, stable patients, but to discontinue in those with severe COVID. SGLT2s are another interesting group. Again, theoretically, they can reduce lactate level and prevent lowering of pH. They can reduce pro-inflammatory cytokines, and it was thought that they might be beneficial in COVID. However, DARE19, which reported earlier, or middle of last year, showed that there was actually no significant reduction in organ dysfunction, death, or improved clinical recovery. There didn't appear to be any significant benefit, and there was a risk of euglycemic DKA. So the advice is for hospitalized patients with severe COVID, insulin is the mainstay of treatment. Ideally, we should stop metformin, TZDs, and SGLT2 inhibitors. DPP4s are interesting. 2 Italian groups reported that people on DPP4s had better outcome of COVID, but this probably just reflected that these were richer people, had better access to healthier food, and generally were healthier. We spoke about TZDs briefly, but because of the risk of edema and heart failure, they really are not ideal in people with severe illness. GLP-1s, again, have the benefit of being anti-inflammatory and reducing weight. However, because of their GI side effects, nausea, vomiting, and aspiration are a risk, and if a person is thought to be at risk, then they should not be used. What about other key medication that we use? Statins have a benefit in patients with COVID-19 and reduce mortality by 50%, so a death rate of 5.2% in those who continue to take statins versus 9.4% in those who stopped. At the outset, because of the ACE2 receptors, there was noise about ACE inhibitors or ARBs being risky. However, there is absolutely no evidence. They may be beneficial, but at worst, they cause no harm. We spoke about dexamethasone before, and this has been the mainstay of treatment of severe diabetes. The recovery trial, which is again led from the UK, showed that with dexamethasone, there was an improvement in patients with severe disease, reduction in mechanical ventilation, reduction in oxygen use, and overall an obvious benefit. What about patients who are admitted with COVID? We spoke about them in detail, but this is a summary that comes out of the joint Diabetes UK ABCD guidance. It's quite detailed guidance. It includes everything, including fluids, monitoring, when you involve the critical care team, how to use the sliding scale, feeding. It's well worth having a read of. One of the key facts is the triple whammy of dexamethasone, COVID-19 induced insulin resistance, and reduced insulin production can cause significant hyperglycemia, and therefore one needs to be aware of managing the diabetes and the risk of DKA. There's a fantastic resource from the Infectious Disease Society, which looks through all the trials, and I'm grateful to Donna Ryan. I've updated this for initially summarizing this. It's put to bed some of the theories, hydroxychloroquine, azathioprine. However, we do have quite a few smiley faces or options that can be used, such as antivirals, lopinavir and ritonavir, which can be used for prophylaxis or mild to moderate disease. We spoke about dexamethasone, monoclonal antibodies for patients with severe disease, which block IL-6, antivirals such as remdesivir for patients with severe disease or patients at risk of severe disease, such as diabetic patients, neutralizing antibodies, and some rheumatoid arthritis drugs. There are other interesting therapies. So it was noted that women had less severe disease. And so this is a beautiful study that took that observation and looked at women with lower estrogen levels, women with supplemented estrogen, and women who were just normal. And they used the normals as 1, and those who had lower estrogen levels, although they crossed the line of unity, had a worse outcome, whereas those who were on estrogen therapy, that conferred a benefit of 0.45. Another interesting finding was of oral famotidine, which is a histamine 2 receptor antagonist used for as an antiacid. And this was found to reduce cytokine release and in people with severe disease, which is driven by cytokines. This did improve outcomes. However, this was a retrospective study, and when it was looked at in a randomized double-blind study, it was safe and well tolerated, and people with mild to moderate disease probably benefited, but we're not sure that it is very helpful for people with severe disease. So what has COVID done that's actually positive? It's done quite a lot of negative stuff, but I believe in diabetes care, it has improved how we function. It has expedited service developments that should have happened years ago, including telephone and video consultations, home medication delivery, the use of technology, and that in itself is a talk, proactive outreach programs such as vaccination, monitoring and treatment of diabetes. And people are keener to have better control because they don't want to get ill. So actually they look after their diabetes better. So in conclusion, people with diabetes do have worse outcomes with COVID-19, but this can be at least in part mitigated by good diabetes control. Uncontrolled diabetes confers a high risk, and we should try and identify and treat these patients. COVID can result in diabetes in about 50% or just less than 50%. That is reversible. It's a combination of insulin deficiency and resistance. Dexamethasone, which is a cornerstone of severe COVID management, can actually make the situation worse. Insulin is the mainstay of therapy. Other medications can be used in milder disease, but in severe disease, metformin, SGLT2s really should be stopped. Education, education, education. And just to remind us that COVID-19 has had some benefits. Thank you.